Infertility does not discriminate. It affects across socioeconomic classes. It affects across ethnic and cultural groups equally. And in that same vein, men and women are both affected in equal fashion. So when you look at the causes of infertility, male factor and female factor actually make up the same percentage. Approximately 30% of the time, it's male factor only, and it's abnormal semen analysis only. About 30% of the time, it's female factor only. So think of things like irregular cycles or blocked tubes. And then another 20% of the time, it's both partners, which is why testing both is so important. And 20% of the time, we actually don't find a reason, and the evaluation is normal.
Hello, everyone. I have my friend, Dr. Carolina Sueldo, here with us today. It has been a long journey to get her on the show. She's such a busy lady, and I'm super, super excited to have her on the show. So, Dr. Sueldo, please tell us a little bit about yourself. Tell us about your journey into medicine, because I think you've had a very, what I call unusual or atypical journey, but it's always been in the same direction. But tell us a little bit about your journey into medicine and how you chose to be an OBGYN.
Absolutely. So first of all, thank you so much for having me. I love what you're doing with this podcast. And I know there was like a lot of planning that went into this, and I'm so glad that we could finally make it happen. So for those who may not know me, I'm Dr. Carolina Sueldo, and I'm actually double board certified in OBGYN and in infertility. My path to medicine, yes, it was unusual. So when I was 15, my parents decided that they wanted to move back to their home country of Argentina. So we packed up all our stuff, we moved down there, and I completed high school and ultimately decided to stay for medical school there. And as I was deciding what I wanted to do, I knew that I loved to help people. I knew I didn't want a desk job. But then when I got into medicine, I loved everything. And my mom, both my parents are physicians. My mom was a psychiatrist, and she said, do what you love, find your passion. You're going to be doing it for the rest of your life. And my father actually was a fertility specialist. And so at the time I said, oh, I want to carve my own path and do my own thing. I'm just going to do general OBGYN. I'm going to really focus on reproductive rights. I had looked at Doctors Without Borders. That was a huge passion of mine, was just reproductive justice and women's reproductive rights. And then once I got into my OBGYN training back here in the States, I was exposed to the IVF laboratory. And there was no turning back for me from that point, because what the embryologists do is nothing short of magic. Like, they really are miracle workers. And it fascinated me both from a medical standpoint. It's a young field. The first IVF baby was only about 40 plus years old at this point. It's a very new field. The studies that we are doing are changing and evolving our medicine and how we approach patients with infertility. So I found that really fascinating from a medical standpoint. And then once I actually got into the specialty or the subspecialty of infertility, I fell in love with it because of the relationship with the patients. It's a very unique field of medicine where it's a very intense bond that you form. The patient has lots of visits in a very condensed amount of time. And it's a very vulnerable moment for them, right? And if you're able to be successful, which many times we are, you've just changed that person's life or that couple's life forever. I've been in practice now 10 years, and I have patients who still send me updates about their kiddos who are now going into 8, 9, 10 years old. So it's been really beautiful. So challenged and excited from like a medical standpoint, and then really fulfilled and just cup filling from a empathetic or relational standpoint. And being 10 years in practice, I was employed for the first 8. And then I opened my own clinic 2 years ago. And so that is a whole other story on its own.
Wow, yeah, your journey is so fascinating, so interesting. And I laugh and I can relate to what you're saying in that when you went into medicine, you wanted to carve your own path, but somehow you ended up following the same path as your father. Yeah. So it's funny how life can throw you some curveballs. You're intending to go one direction and you get pulled in another direction, but also makes me think or wonder if some of these things are actually a calling. It makes me wonder how much control do we really have of our own lives or what we think that we're going to do. And I also love the fact that it still at the same time combines both the specialties that your parents have, because you talk a lot about bonding with your patients, and a lot of psychiatry is indeed involved no matter what field of medicine you're doing. There is a psychological component, and you have to be able to connect with your patients. And I think there's studies out saying that if people have a better relationship with their physician, they're more likely to do well. And especially female surgeons, if a patient has a female surgeon as their doctor, outcomes are better. So I think that's really special that you recognize the fact that it's not just about the medicine, it's also about the connection that you have with your patients.
For sure. Totally. Could not agree more.
The first question I want to ask you after talking about your path or your journey into REI is, what are some of the common causes of infertility in both men and women?
Yeah, so I love this question because I think it's really underestimated. What I share with my patients is that infertility does not discriminate. It affects across socioeconomic classes, it affects across ethnic and cultural groups equally. And in that same vein, men and women are both affected in equal fashion. So when you look at the causes of infertility, male factor and female factor actually make up the same percentage. So when we're evaluating a female as part of a heterosexual couple, we always want to make sure that we're including a semen analysis in that evaluation. We know that approximately 30% of the time it's male factor only and it's abnormal semen analysis only. About 30% of the time it's female factor only. So think of things like irregular cycles or blocked tubes. And then another 20% of the time it's both partners, which is why testing both is so important. And 20% of the time we actually don't find a reason and the evaluation is normal. And that technically has a label of unexplained infertility. I really prefer the term undiagnosed infertility. And essentially, what I share with my patients is that the testing available today is not finding whatever it is that's going on with them.
That is very fascinating. And I think for our audience, especially those who are not in the medical field, it just goes to show that as physicians, we don't know everything. There are those unknown variables, and sometimes we'll eventually come up with an answer. But I like the fact that you acknowledge that it's unknown. It doesn't mean that we will never know, but there are some variables that are unknown. In terms of a couple who's thinking or considering seeing REI specialist, how long should they wait before they consult either their family doctor to send them a referral to see somebody like you, or to even see their OBGYN?
So if we talk about guidelines, like what do the textbooks say? There's a very clear time component. If the female partner is under the age of 35 years old, then we typically say unprotected intercourse for a year. Beyond that, they need to be evaluated. So 12 months, and then after that, they should really see somebody. If the female partner is over 35 years old, then we typically shorten that to 6 months. So that time component is very critical as it relates to the female's age. Now, that said, I always tell patients there's going to be caveats to that, because if you are having irregular cycles, so let's say your menses comes every 3 months or every 6 months, there's no way that you're ovulating in any sort of regular or predictable fashion. So in that patient, I'm not going to tell them to wait a year. I'm going to say, hey, you haven't had a period in 3 months, you need to go get evaluated because you're not ovulating. And so you're going to want to jump into testing and treatment much sooner than somebody who's getting that regular, predictable monthly bleed. The other thing, for example, is if they have known risk factors for infertility. So let's say they've had a history of an STD like gonorrhea or chlamydia that could impact the fallopian tubes. Let's say there's a history of prior surgery, or in the male's case, prior trauma to the testicle. Anything that could be a risk factor for infertility. Maybe a patient has known fibroids that she's been struggling with in her uterus throughout her, maybe she was originally being seen for heavy periods, but we know that fibroids can be a risk factor for infertility. So those are all scenarios where that time component of 1 year or 6 months, that goes out the window. And ideally, you want to be proactive and you want to get in for testing sooner, because then you can make informed decisions about how quickly you'll move into treatment. For some patients, it could be as simple as, hey, we did the testing, everything was normal, and so we're going to keep trying for a few more months. Or no, hey, we found something and we need to have a conversation about it.
That's great. Thank you for pointing that out. And just to confirm, is there an age limit for men as to when they should start to think about whether they might have infertility? A lot of people are getting married later or having second or third relationship. So on the gentleman's side, is there a certain age that they should be a little bit more proactive at?
I love that question. So the short answer is yes, but it's a lot more nuanced. So from the literature, we know that advanced maternal age is pretty clearly defined at 35 and above. And there's actually a second breakpoint after age 40 where the drop off is even more dramatic. So I always envision for the female this diagonal line down between 35 and 40, and then that becomes vertical after 40. In the male, we know that it's not quite as defined. We believe that depending on the study that you read, there is advanced paternal age, We do see a decline in testicular function and sort of the male version of menopause, but that tends to begin somewhere around the age of 45 to 50 in the male partner, and is not as linear as it is in the female. So you may have a large segment of the population that is still producing normal semen samples well into their 60s, 70s, and 80s. I think, up until recently, I think Charlie Chaplin was most famous. He had a child at the age of 82. I think now Al Pacino or Robert De Niro they both just had young children in their late 70s. So we know that the testicle contains the cells, they're called germ cells, that can generate new sperm the male fertility decline is present, but is much less well understood than female infertility decline.
Okay, good to know. Good to know. Thank you for explaining that. And I think also using examples that people can relate to explain what we observe in society. The next question I want to ask you is for people who, either don't have access to an OBGYN or somebody that specializes in REI, or who also want to be proactive in improving their fertility. Are there any natural things that they can do to optimize their fertility?
I literally saw this question in a Facebook group this morning. So the answer is yes. I want to be very clear. I think that when we talk about infertility, we need to be very careful, and we need to specify that it is an underlying medical condition. Like, you are not responsible. You do not have infertility because it's your fault of something that you did, right? It is an underlying medical condition, just like high blood pressure, just like thyroid disease, et cetera, and should be treated as such. However, just like in those other diseases, we do know that integrative medicine, so lifestyle, is going to have a huge role in optimizing the patient's chances for success. Some of the things that I talk about with all of my patients is, how is your weight health? Is your BMI too low? Is your BMI too high? Extremes in that weight, either high or low, extremes in that weight can absolutely play a role in fertility, can impact cycle regularity, can impact sperm production in the male. So there's a huge impact in weight health. So what is that like for you? Have there been any changes? The other thing I talk to them is, what is your daily nutrition? There's not really a fertility specific diet, but focusing on the Mediterranean diet seems to be the most appropriate for overall health, overall longevity, and that translates into reproduction. Liquid calories, particularly in the US diet, think of things like juices, sodas, creamer in your coffee, et cetera, which can be very easily missed. You're like, oh yeah, I'm super healthy, I eat really great, but there's all these additional calories, carbohydrates that are not being accounted for. The last thing I like to talk about is sleep. So we know there's actually well-documented research that in night shift workers who are awake all night and sleeping during the day, they have higher rates of infertility, higher rates of menstrual irregularity. And so we absolutely know that disruptions in the circadian rhythm can impact infertility. We see in PCOS patients, for example, they have a higher risk of sleep apnea that can impact oxygenation and how much oxygen your tissues are getting overnight. And that can impact fertility in the long run, et cetera, et cetera. So really taking stock. And why is this important? Because usually, not always, but usually the fertility specialist is the last line of defense. Usually, most couples have been trying on their own for some time. Maybe they've spoken with their primary care physician about it. Maybe they've spoken with their OBGYN about it. Maybe some preliminary testing has been done. So again, not always, but usually most patients come to me after 1+, 2+ years of trying, in some cases longer than that. And I'm going to be going through all of this, right? So I don't want to be 2 years into your journey, and now we're talking about your vaping habit and how that can impact parameters or egg quality, right? We're thinking about IVF, and all of a sudden, oh, but should I do a GLP-1 before the month before, or whatever? Like, as much as the patients can optimize ahead of time at the start of their journey, that's really what's going to set them up for success. Now, you may still need to see me. You may still need treatment. You may still need IVF, but at least we're already optimized for all of those other factors. So lifestyle, I think, is hugely important. As far as supplements go, I generally recommend a prenatal vitamin with at least 400 micrograms of folic acid in it. That's the current guidelines from the medical societies here in the US. And really, supplements, it's a multi-billion-dollar industry, right? And it's not regulated by the FDA. So depending on every patient's particular scenario, There may be additional supplements that I recommend for those patients, but it's so tailored, it's so individualized, it's really hard to give kind of general guidelines on what might be helpful for everybody. And then the last thing I like to talk about is integrative practices.
Mm-hmm.
For those who are open to it, for those who believe in it, I do think that things like regular practices of meditation, acupuncture, some of the yoga, some of those Eastern practices can absolutely be beneficial. And here, I practice in Fort Lauderdale, Florida. Here in South Florida, it's a very collaborative effort that I have with my regional acupuncturist to make sure that we are synergizing for the patient's success.
Wow, wow, that is fantastic. That is fantastic. Thank you for breaking that down. And I think you have some social media channels for people who love everything that you're saying and they want to have more in-depth information from you. Please let us know where people can follow you online.
Oh, sure, absolutely. I am on Instagram and Facebook as just my name, Dr. Carolina Sueldo. Our clinic also has an Instagram and Facebook account, Ceibo Fertility Center, Ceibo spelled Ceibo. And then I also have a YouTube channel. There's some really great videos, really great education on there. They're short, they're not long, and I think break it down pretty nicely. And for those who want to learn more, they're always welcome to go to our website at ceibofertilitycenter.com. You can submit an inquiry, and I would love to connect with you.
We will make sure to have all her social media handles and her office her office and her business website online so that you guys can connect with Dr. Sueldo and learn more about her. I'm going to sneak in maybe one or two more questions before I let you go.
Sure.
So you touched on a lot of interesting things, and I'm like, where do I go? I think I'll go straight for the Ozempic one because that's trending right now. So for women who are on a weight loss journey, maybe they've been told that their weight is playing a role in their ability to conceive, and they're thinking about taking Ozempic. Do they need to make any considerations, perhaps before starting Ozempic, or if they're already on Ozempic? And what is all this business people are saying about Ozempic babies? Is it true that people who start Ozempic are more likely to give birth? Please fill us in.
Yeah, I love this question. So I'll lead with, I think that the GLP-1s in general, so whether it's Ozempic, Wegovy, Mounjaro, any of those sort of newer generation medications, have truly revolutionized how we approach the weight health journey. And in my world of fertility, specifically targeted weight loss to optimize for fertility, or my PCOS patients. Remember, PCOS affects 13% of reproductive age women here in the US, and they struggle with that metabolic component of the disease. So I really think for the first time in a long time, certainly since I've been in training since 2008, it's the first time we've seen something truly change the paradigm of how we are counseling patients and what we're able to offer patients. So I personally am a huge fan of GLP-1s when they are done properly with a medical specialist who is well-versed and educated about the use of GLP-1s and who is going to monitor and supervise the patient during that GLP-1 journey. So I want to start with that. I think those are some foundational concepts that are important to highlight. When we're talking about the Ozempic baby craze, so going back to the impact of weight on fertility, without getting too extremely technical, there is an enzyme in the fatty tissue called aromatase. And that enzyme basically makes estrogen. So what happens, the way I think about it when I'm counseling patients is your brain and your ovary, or your brain and your testicle, either one, they have to be able to talk clearly, like you and I are talking right now. The more fatty tissue that you have in your body, the more estrogen that's circulating. Now imagine that those two people are trying to talk in a crowded conference room with all this chatter in between, right? That signal is just not going to communicate clearly. And so what we see is that there is a large percentage of the population that was having irregular cycles or ovulatory dysfunction because of their weight health. And with the rapid weight loss, we see a return to baseline where ovulatory function returns, and then ovulation happens, and maybe without the patient knowing, and then pregnancy can occur. So that is the simplest, most well-known way that I envision the Ozempic baby happening. I'm sure that there are more nuanced components to it. We know that the GLP-1s can be anti-inflammatory as well. So I don't think we fully understand the impact, but the general concept is that with that weight health journey and with that weight loss, patients are seeing a return to a more fertile state. and hence they are able to get pregnant. So it's not that the GLP-1 is actually causing pregnancy or making them more fertile. It's that return to baseline that enhances fertility or optimizes for fertility. And then as far as its use in the fertility journey and the fertility treatment journey, currently the manufacturers say that it should be approximately 8 weeks to stop, 8 weeks from conception. And so we have tried to respect that. We're not totally sure where that 8 weeks comes from. What we do see is that at least the babies that have been born in this time do not appear to have a higher risk of any sort of genetic anomalies or birth defects. But it's all the data so new that we just don't really have enough information to give robust recommendations, right? So we're always going to err on the side of caution. Generally speaking, for somebody who's on a weight health journey, by the time that they come to see me, and we typically will do a few weeks of testing, and then we'll go into their first treatment month. So by the time they get to that positive pregnancy test, even if they get pregnant in that first treatment cycle, they're already in that 8-week mark. So that's typically how I've been recommending patients.
That is awesome. Thank you for breaking that down. I think you're right. We still have so much to learn about how these medications work. For now, they're helping so many people, but thank you for breaking that down. So I think I'm going to have you back because I still have more questions I'd love to ask you.
I'd love to come back.
Thank you so much for taking the time to talk with us and to answer all of our questions. For those of you who are in the Southern Florida or even Florida area, and you're looking for somebody to help you on your fertility journey, you should consider reaching out to Dr. Sueldo, and we'll make sure that we have all her contact information below the show notes so that you guys can reach out to her. For those of you who are regular audience members, thank you for taking the time to listen to us, and we look forward to talking to you again. Bye-bye for now.